Welcome to MAP, the bi-weekly market access podcast provided by Mars Market Access and Pricing Strategy, which is your healthcare consultancy in the German-speaking markets. Mars makes it as easy as possible for you to get your pharmaceutical, medtech, or digital health product to the market and, of course, get the price it deserves. My name is Stefan Walzer. I'm the founder of Mars and a health economist by training and working in the fields of market access, reimbursement, pricing, and health economics already since 2004. And now let's learn about the market access and reimbursement systems around the globe. Market access is not always easy. I would rather say a lot of times more complex in Germany. Today we're focusing a lot more now on a very special topic where we might also focus a lot more on medical devices and we might only touch base in a short kind of time frame on drugs and diagnostics, for example. Why is that? Just keep in mind that for medical devices, there might be maybe and sometimes, depending a bit on the medical device itself, various market access pathways. For example, if there is a digital health product, risk class 1 and 2A, there might especially be the DiGA pathway applicable. But sometimes, even with the risk class 2A, for example, there could also be the method evaluation, especially if it's seen as a new method, which would then need to go through the GBA. So why is that important? As we all know, the method evaluation might take quite a long time with the GBA, which would especially mean if you have a medical device in the outpatient setting that there are no cash flows, meaning no revenues for the product as you cannot sell it in the outpatient market. Another option is basically think about a medical device which can be sold potentially in the inpatient setting, but there might potentially be already a kind of product which is similar. Hence, you might potentially not even get an NUB, meaning a Zusatzentgelt afterwards, which is then the additional kind of payment, the additional funding for it. And that would basically mean that you need another solution if you want to really sell it. So a lot of different examples, and I think the most prominent one for selective contract, because this is then where you could potentially approach health insurances. They want firstly, obviously, to think about how to improve health care. That's also an important consideration when thinking about it. Payers are not asking firstly for the cost and the price. They first of all, and especially if you speak and discuss about selective contract, they want to understand the healthcare impact. Once you have answered that, then there might be obviously a couple of further rounds, further understandings, the population within the insurance companies, and also then finally the price. How could this happen? We're still having 97 health insurances. And the most prominent example for me is still the Abbott diabetes patch, which has been, let's say, released and done a couple of years ago. And I think best to discuss this kind of issue, very interesting discussion today, is with Tim Hering. He is the general manager for a couple of different consultancies, but all focusing on healthcare management. And that basically means bringing those kind of contracts into life, so into the daily, local and regional care context of patients. Okay, Tim, thank you to be with us today, and we can directly dive into the topic. You're an expert in the, let's say, care context, and especially also in terms of contracting. So maybe you can firstly explain what German means with the terminology of selective contracts.
Hi, Stefan. Thank you very much for being here. And I think we have a good deep dive in the in this topic with the selective contracts. Let's start. I think we have got the first challenge in the difference between the German healthcare system and I think all other healthcare systems in the world. And so we have got some specific rules for Germany, and the selective contracts are especially for the public health insurances, which covers about 90% of the 80 million inhabitants of Germany. And for these insured persons, we have got several opportunities for medical care options.
Thank you, Tim. This is obviously a kind of introduction, right? And very important. But what is now a selective contract?
Yeah, definitely right. We have got the Sozialgesetzbuch number 5, where everything is described what is allowed for the medical care in Germany in the inpatient and outpatient sector. And we have got special codes which allow the public health insurance companies to close selective contracts with inpatient and outpatient doctors and clinics, but also with manufacturers. Therefore, everybody needs the knowledge about which codes, which paragraphs are allowed for a public health insurance company to negotiate special medical themes. And therefore, especially the 140A, the selective contract called integrierte Versorgung, is the most common way for a selective contract within a health insurance company in Germany.
Okay, perfect. Yes, I think integrated care contract. Yes, that's, this is also obviously, I think, quite complex, and we're probably covering that as well in a minute. You have mentioned already that, let's say, the statutory or the public health insurances in Germany are covering roughly 90% of the population. On top, I would maybe add the further complexity that we're still speaking about 97 health insurances, right? So how would you deal with that? I mean, we have a lot of very, very small insurances, and then a few which are really large, like the TK, the DAK, etc. But how would you deal with that if, let's say, a company would approach you and just say, look, I have a problem, I would like to go into a contract, how to best, let's say, approach, what would be the kind of maybe criteria to select one or the other insurance?
Yes, definitely right. This is one of the specialties of the German healthcare system, that we have got the market leader of the TK with a market share of about maybe 15%. So this is really small for a market leader. If we would combine it with an industry market. So we have about 100 or 97 public health insurance companies. So as you can see, it is a long run. It is not a sprint. So you have to take time to get in contact with all these health insurance companies. And if you start to get in contact with a health insurance company, everybody sees TK and Barmer. So there are always the most manufacturers talking to this health insurance companies. But there are several other opportunities with smaller ones, Betriebskrankenkassen, Innungskrankenkassen, but also with the AOKs, Allgemeine Ortskrankenkassen. And some of them are very likely for a contract because they are focused on a special region in Germany. And this is what the manufacturer should think about. Do you want to cover whole Germany, or do you have some hotspots where you will be represented and have a kind of success story for the other health insurance companies to say, look at this, they have started, we have got success in this area. Do you want to be part of it, or do you want to get an own contract with us? I think this is a good way.
Yeah, I think that makes a lot of sense. I mean, it is obviously the kind of core question, how to approach then the market, right? I mean, directly nationally, or maybe stepwise, as you just described it, with maybe the BKKs, IKKs, or the AOKs, obviously, because I think you said market leaders, but if you have a look on the regional level, sometimes we have as well on regional level AOKs being the clear market leader as well. So that as well maybe something keeping in mind. The other point what I was thinking about is when you say more a regional approach, how does that fit with maybe the clinical involvement, so the KOLs, the clinical centers? Because I could imagine, and we have seen that as well, that obviously if you have, somewhere, maybe in a region, a strong KOL supporting you, that it maybe makes even more sense to start there with a region, could be a larger region, right? But with a region instead of directly going on a national level and then trying to spread it. What is your opinion on that?
I would totally agree with that, because it's always a people's business. The doctors in the inpatient or outpatient sector has to be convinced that this offer is a value, a benefit for their patients and for their own work and for the people who are working with the patients. So if it's a people's business, you need experts to convince that this is it's a good new idea. And if you have got a selective contract, it will never work without the medical part with the doctors in the inpatient and outpatient sector. So it is obvious that that you need in the beginning a focus on a special region and the people in this region, and only with the support of these persons, a selective contract will be success. I think this is one of the key success factors for a good contract, and you have to start with one. Yeah,
exactly. I know. I can fully imagine. I mean, to me, or our let's say experience, and we're not a driver in terms of those contractings, but we have supported some more in the background. It was, let's say, sometimes also a bit surprising for one or the other client that when you approach a health insurance company, maybe even have a first meeting with them, that they don't start with cost and price. I mean, that is still in the mindset of a lot of people that mainly costs are the big driver. What do you think about that? Is that really the truth, that maybe health insurances are not firstly discussing about cost, but especially if you want to have maybe an integrated care contract, that they first start with a care environment and maybe with the question how to improve care for patients?
Mm-hmm. This is an interesting topic, and I think we have to answer two different levels. And the first one is, of course, in the conversation you start with the aspects of benefits for the patients and how a new way will improve the medical care situation in this area. But on the other hand, and this is not outspoken, it's but in everybody's mind, is there have to be benefits as well on the cost level. And if you cannot show this impact on the cost level, it won't work. It's quite easy. It won't work. And we've got another challenge in the health insurance companies. I think they have got all the data in their hand, but they do not have the tools for analysis their data. So they need help. They need help how they should watch on their own data to find what the manufacturer is telling them, which benefits there are.
Yeah. I think you're probably bringing up another important point. I mean, if I'm aware of, I think also health insurances would need to show that a contract is, let's say, somehow beneficial also in the legal frame, right? Meaning that ultimately they would as well need to show some kind of, as you called it, benefit in either directions, right? So either cost savings or maybe somehow an improvement for patients. But obviously with the contract, you do not want to run another randomized controlled trial or anything like that. So it is probably something to think of as well. What could be measured, I guess, in a contract or within the health insurance data, and how could you then as well show the benefit of that product? How, or let's say, what are the steps behind there? I mean, how do you try to find then a solution there?
One of the biggest issue a health insurance company has is how do they have a control that the right patients are getting in the selective contract. Mm-hmm. And therefore, I need kind of a control system or someone who is doing the work in the health insurance company to bring the people in the medical care situation. And this is not so easy as it might seems. And therefore, all partners need data to say, how can I describe the benefit and how can I measure it afterwards? And I only need the right persons at the right places, the right patients at the right places. And this is a little bit more complicated, as all parties think at the beginning of the negotiations.
I could fully imagine, fully agree. We have now spoken quite a lot about, let's say, the statutory, the public health insurance, but there's still that 10% of the population, 10% of 80 million is still 8 million, right? Which is the size of the Netherlands or Switzerland or Austria, with the private health insurances. Are there any differences in terms of approach when I compare the statutory versus the private health insurance? And especially when thinking about the contract, or would you just say contract is not the kind of core thing, especially when thinking about an integrated care contract for the private health insurances?
I think from the story you tell, a public health insurance company is not completely different to a private health insurance company, but it's so different that you have, I think, two slots. One slot for the storyline for the public health insurance company and the private ones. And you have to see the private ones. There are also a lot of companies, and they have got their patients or insured persons all across Germany, so they do not have a marketable market share in the region. So, and this is totally different to a small BKK, which might have an industry partner in that region and has got a market share in that region of about 40 or maybe 50%. And also the AOK, they have got an average 30+% market share. So they are good partners. And a private health insurance company is not reaching that market shares. So as you see, you might have 500,000 insured persons at one company and maybe 1 million, maybe. But how do you reach these persons? And therefore, you need a good story the company will share when you tell them this is the new way to work. So, and from that perspective, DiGAs or digital offers for the healthcare systems are quite interesting because you do not need the regional aspect, and this is kind of a game changer right now. It's maybe it's a turning point. Because we started with this topic right now with DiGAs and DPAs and kind of that, but we do not have any studies how it works and how especially the outpatient doctors are willing to use these options. This is a kind of change we are running through right now. And we will answer this question in about 5 years, and we will hear this podcast and maybe think, oh, interesting option or not.
That's a very good one. Yes, I fully agree. And I mean, you're just opening up another interesting and good point. I mean, what makes a medical device really attractive for health insurance in order to really think about a contract? Because obviously we know that it's also quite resource intense also at the beginning, right? Meaning you need to put the contract together, you need to agree, you need to discuss, you need to align, maybe you need to run some further analysis. So it's not just, we just go there and just do it, right? So what makes it really attractive? You just brought in the digital part, right? Where I just thought, that's maybe one solution. If it's maybe not a DiGA or maybe also for potential DiGAs, I think that's maybe another question, but it's probably more general. What makes it really attractive?
Just in Germany, you say it's very hard to get into the healthcare system, and it's even harder to get out. So if you're once in, it will bring you plannable revenues. So I think the German healthcare system has a high attraction for manufacturers for medical devices, but you have to do it right. And what I always watch or often watch for manufacturers is that they get too pointed in a medical theme. And this is not the view of a health insurance company. They have to cut the costs for the whole treatment, not only for part of the treatment. So you have to change the point of view to a more holistic area, and then see how can I help the health insurance company to solve their problem. And we are a team. It's not I've got an idea and please follow my idea. It's how can we do it together as partners? And the health insurance companies often saw that this partnership is not wanted, or the partners do not live this partnership. And I think there's a good chance. This is a highly, highly good chance to see where can we do it better. And often the inpatient and outpatient doctors, the health insurance company and the manufacturers have the same aims. And we can do it better because there are insufficient situations right now. And to change this situation, there will be the profit, the benefit for all partners.
Yeah, I think that's a very good point. I think just keeping in mind that ultimately all stakeholders should be somehow some kind of partners, right? And with partners, I mean, you also sometimes have debates, discussions, etc. But at the end of the day, you should have the same goal. I think that's a very good point you just raised.
Because just let me mention this point. A contract has to bring benefits to all partners of the contract. And if one partner doesn't see the benefits for him or her, they will end up the contract. And you need so much time and you need so much conviction in the starting phase. You have to do it right to get the contract, and you need only small efforts to keep this contract run if you do it right at the beginning.
Yeah, exactly. I mean, have they let's say success and the aim in mind? That's the end, right? But start obviously early on to plan all together in order to make it successful. But as you said, for all parties, I mean, integrated care contracts, obviously the health insurance, the care providers, right, the physicians, and then also the company, which is maybe then just a small part even of that contract. That's a very good point. Coming to the end,
partner is the payer of the party, so you have to treat him well. And don't forget.
Yes. So, I mean, coming more towards the end, if you would have, let's say, the one recommendation for a company, for the industry, besides obviously contacting you if they want to run a contract in Germany, what would that be? I mean, what is the one thing you say, think about this or do that before anything else?
I think the biggest impact is to be focused. Mm-hmm. To be focused on the storyline and be patient because the German healthcare system is working, but not fast, but it's working efficiently, but slow. And take your time, be focused, and to being focused means also find a region where your storyline is really working and bring this region to a success. And I think a side topic is data. To convince partners to do the right thing means to speak the same language, and the language is data, and to have the same view on the topics. And I think to combine data with a regional focus and to be pointed on your topic, then there can go nothing wrong.
That's perfect. Yeah, I think you summarized.
If you've got the right product. If you've got this is
exactly. But you know, I mean, you said already, right? I mean, you need to bring it, or let's say you need to find, especially the kind of region, and then bring it to success there. And I mean, if you don't have the right product, you will not be successful there. And hence, from a very small kind of region, you cannot even go even broader, right? Because it would probably be seen more as, I don't want to say failure, but at least not a success. So being patient, being focused, find the right kind of region and then try to bring it from that smaller maybe region into the broader scope into Germany. And I think, as you said, be patient, which is sometimes difficult, but the German system is just as it is.
Exactly. This is absolutely true.
Perfect.
It's very special. It's special. And you do not have to understand why it's working that way. And of course, there are many potentials for optimization, but we can't change everything right now. So we have to work with that what we find, and it's working. Slow, but working.
That's true. That's a perfect end of our discussion. Thank you, Tim. It was great to speak to you.
Thank you, Stefan. Have a good time.
So great insights from Tim Herring around contracting, and I think also the special steps around it. So very importantly, as he laid out as well, is, let's say, early planning and a clear kind of, let's say, targeting where your product could potentially be beneficial, firstly for the patient, meaning that the care could be improved, and then finally maybe as well for a region, meaning that this is as well a surplus for the health insurance company. On top, quite clearly, when you would need or want to go into that kind of area around integrative selective contracting, keep in mind that maybe you need to start quite small in a way. That means maybe going and starting in a region. A region could even be a so-called Bundesland, right, which is also already quite large in some ways, depending a bit where you go. For example, Baden-Württemberg in the southwest is already roughly 8 million inhabitants. If you get, for example, there a contract with the AOK, market leader there with roughly 40-45% of the population there, you have already a quite good number of patients. In any way, very important, just keep thinking, going step by step, very prioritized, and quite clearly show an improvement and taking the health insurance company as a partner, meaning also when you start discussing with them, yes, for sure it's a negotiation, because that ultimately you need as well to agree on the price for your device, which is then part of the contract, not the only part, but a part of it, as also other components, other stakeholders would potentially need to be involved. Having said that, very important, even before that, quite clearly, the involvement and the buy-in alignment with the German KOLs is of utmost importance, as always, if you want to say, let's say, successfully launch the product in Germany. That was an episode of MAP, the Market Access podcast provided by Mars Market Access and Pricing Strategy, which is your healthcare consultancy in the German-speaking markets. MAP is available every second week with a new episode, so watch out. And in case you might have questions, contact me directly and or visit our website on www.marketaccess-pricingstrategy.de.